Good afternoon, Unite for Her. Welcome to November on this chilly Thursday.
Yeah, it's so good to have everybody. And we again have an amazing segment led by Erin here with our education director. And we're really happy that you joined us because I think, you're going to find this incredibly interesting when we lean into our young community like this and really understand what's coming up in the future.
Yeah, absolutely. This is a great topic with someone that does a lot of work and a lot of research in the young adult cancer survivor thriver space. So we are really excited to be able to share what is new in supportive care for these young patients that are diagnosed with cancer. So we're really excited to have our speaker with us today.
Yeah. And as you all know, we are live here on Facebook. So if you have questions, please put them into the feed. We have our very own Rachel watching our feed and feeding those questions to us. And of course, we have several that we've already grabbed from our community, Erin, that we're going to be going through. So really excited to have this live interactive conversation in real time. And hopefully we will be able to get to all the questions that come our way.
Absolutely. And we know that not everyone is able to join us on an afternoon, especially leading into the holidays. So we are recording our Ask the Experts today. It will be up on our Her library. So if you know anyone that where this information could resonate with them or could be an additional supportive arm, please send them to our video library. We'll make sure that this is up probably this afternoon, but at the very least by the weekend. So definitely share that link along.
Yes, you got it.
Wonderful.
And then, of course, we can't do what we do without our sponsors. Unite for Her is a very robust digital education platform. And this is one of those areas, the Ask the Experts. And we can't do it without the support of those that are there to really be by our side. So we would like to thank our presenting sponsors, which are Wes Merck and Daiichi Sankyo, with additional support from Lilly, GSK, Gilead Sciences, Pfizer, and Immunogen, which is now a part of AbbVie. Again, we do over 40 of these segments a year. We have incredible experts that come on, just like we are going to be introducing you to in just a moment. And we could not do what we do without this support and this trust and just being by our side all this time.
Yep, absolutely. We're so grateful to them. All right. And I will jump in to share a little bit of what we have coming up in December, because it's hard to believe that we are at this part of the year, but we have some new topics that we're covering, and we have some returning guests that we like to bring in during the holiday season when it can be a little bit more stressful. So to kick off December, we will be starting with our speaker series on Tuesday, December 3rd at 6 p.m. This will be also wonderful. We'll be unveiling our Giving Tuesday campaign, but we will be joined by a very close, dear partner and medical advisor of Unite for Her, Dr. Lola Fayanju of Penn Medicine, who will be going over cancer recurrence, understanding why it happens, what are the risks, how a person can reduce their risk of potential recurrence. So really leaning into more of the medical discussion behind that. And we just love Dr. Fayanju. So we know it'll be a very engaged segment. And I've already had several of our Unite for Her communities, sort of pinging me saying, make sure I register for that segment. So we're really excited to have her for our speaker series. And then we are bringing back our friends from Twist Out Cancer. So Jacqueline Carmody, many of you, if you've ever connected with Twist Out Cancer, I'm sure are aware of the wonderful work that she does. And she will be joining us for our virtual hangout on Wednesday, December 4th at 5 p.m. Eastern Time. And we'll be leaning into some art therapy. And Jacqueline will be focusing on the 5 love languages. So that is a book and a discussion that perhaps many of you are familiar with. So we'll be doing creative work on Canvas as we discover our own love language and that of our loved ones. So I'm really excited. I think it's a great way to lean into just love this time of year. But as always, like I said earlier, if you're not able to join us, both of our segments will be recorded and available in our Her library, which you can access all of our past segments as well at uniteforher.org/herlibrary.
Yeah, I got to see your post on that, five love languages too in art therapy. That was a
Yeah.
fun one.
Yeah, we're so
Sure
excited.
you,
I know
make
I'm
sure
looking.
you get over to our Instagram and you can see Erin talking about that one as well. Back to
Absolutely.
back, third and fourth, Erin.
I
That's
know, kicking
a good
off the
week
month in a
ahead.
strong way.
Yeah, that's so good.
Yep. Good.
All right, wonderful. So I think we're ready to bring our guest on,
Would love that.
our
So
expert of the evening.
perfect. So let me share a little bit about our expert today. She is truly incredible. So Shoshana Rosenberg is a cancer epidemiologist whose research focuses on survivorship, quality of life, and treatment decisions in the young adults with breast cancer population. Additionally, she's involved in designing and incorporating patient-reported outcome measures into observational studies as well as therapeutic breast cancer clinical trials. She received her BA from Binghamton University, completed a Master of Public Health degree at NYU, and a Doctor of Science degree in epidemiology at the Harvard T.H. Chan School of Public Health. Following an NCI postdoctoral fellowship in cancer prevention, she was a faculty member at Dana-Farber and Harvard Medical School before joining the faculty at Weill Cornell Medicine in May 2021. This is where she is currently an associate professor in the Department of Population Health Sciences and co-leads the Cancer Control and Prevention Program at the Meyer Cancer Center. Please join me in welcoming our expert today, Shoshana Rosenberg.
Thank you so much,
Hi,
Erin and
Shoshana.
Sue, for having me.
Yeah, we're so happy to have you. Really appreciate you being here and diving in.
Sure.
Absolutely. Yeah. And this is really, this is a discussion that I think often goes over, not so much overlooked, but isn't as prevalent for this population of breast cancer. And Sue, I know you and I were talking a little bit before this just about how far supportive services have come. So, it's exciting to hear how we're utilizing technology and leaning into different populations. So, with that, I thought a great place to start would be in this population, sort of leaning in more to the pregnancy and breastfeeding space for our young breast cancer survivors and thrivers. And I know that there's a trial that's going on, the positive trial specific to this population. So, Shoshana, can you share with us a little bit about what that trial is looking at?
Sure, yeah. So I'll just, start by way of background, how like we all know that young adults with breast cancer, young adults with all types of cancer, they have these, really salient issues that are relevant to their lives. And fertility is a major one. Whether you have kids already and want more, or, you don't have kids yet, or you're not partnered, fertility, pregnancy, we know for a long time that's a major issue. And there's been a lot of exciting research going on, I would say, over the last 20 years, that's really, looked at what are the concerns, what are the prevalence of those concerns, where are we with fertility preservation? Is it being offered to, our young patients? And kind of the pregnancy, what's happening after breast cancer diagnosis, especially for younger women, are they able to become pregnant if they want to? That's a question that was not answered in a rigorous way for a while. And we're fortunate that we've had a lot of what we call observational data, or types of studies that have tried to go back retrospectively to see, is it safe to become pregnant after a breast cancer diagnosis? But what the positive trial really brought to the table and was informative, and it's still ongoing. Follow-up is still ongoing, but the main results were reported out and published. I believe it's last year. I'm getting a little confused if it was last year, the year before, very recently. And I'll go into the positive trial in a little bit, but it was really the first prospective trial that aimed to answer the question of whether among specifically women who are diagnosed with hormone receptor positive breast cancer can safely pause tamoxifen to attempt pregnancy, or endocrine therapy to attempt pregnancy, and then hopefully become pregnant and then resume their endocrine therapy after a short period of time of becoming pregnant and if desiring to breastfeed, but then go back on ultimately. So really the positive trial was designed to answer that question. And I'll go into a little bit of the detail about the design and what the findings were. But really it's a landmark study. It took a village to design and conduct. It's answered a really important question. And of course, the women who are enrolled in positive are followed, so we can, reassure women that hopefully in the longer term, it is safe to have a baby after breast cancer.
Wow. And how long, if I may ask, that trial, how long has that been going on? So you're saying that they're continuing to follow up?
Yeah. So the enrollment period was between 2014 and 2019, and it's an international study. And over that 5-year time period, over 500 women from multiple countries were enrolled. So it's an international multi-site clinical trial. And they enrolled the women over that time. They had to have had early stage breast cancer, stage 1, 2, or 3, hormone receptor positive. And they had to, desire a future pregnancy to enroll into the trial. Another kind of key enrollment or eligibility criteria was they had to have at least had received endocrine therapy for at least 18 months before stopping. So they had to have that period of time where they were taking endocrine therapy. And they temporarily paused it and then tried to become pregnant. They could have had fertility preservation. They didn't have to, and have no evidence of recurrence when they enrolled on the study. So that was kind of the enrollment and the eligibility criteria. And then 2019 enrollment closed, and then just followed those women to see what happened, see if they became pregnant. Ultimately the question that the study was designed to answer was around safety of pregnancy. So are the women who are becoming pregnant hopefully are not at increased risk of recurrence compared to women who don't become pregnant. And they use, this wasn't a randomized trial because you can't randomize women to become pregnant versus, not become pregnant. So they used a historical kind of control group to kind of estimate, what a risk of recurrence would be in a group that, didn't become pregnant, and compared that to, what they saw in the group that became pregnant in the positive trial. So that was the design, and I'll briefly share some of the primary results, and I'll talk a little bit later after I share this about, some of the other findings from the study and what other data they're collecting, because that's the great thing about these studies. You design it to study what a primary research question, but you often have the opportunity to answer a lot of other questions. But the good news is that the primary results were very encouraging. About 3/4 of the women who attempted to become pregnant had at least one pregnancy. There are some women who became pregnant more than once. Over 80% did have a live birth. And as of the last follow-up, before they report the results, 9% of positive trial participants experienced a recurrence, and that was about the same to that control population that didn't. So yeah, so very reassuring, at least in the shorter term, and they continue to follow these women. So hopefully, the next report out will hopefully also be similarly reassuring.
Yeah, Shoshana, that makes me so happy. I can't tell you. That was me. That was me 20 years ago. And my choice was don't take it, because that's all there was. Don't take it. If you want to have a child, have more children. I have 3, and I did want to have more children. So I did it. I didn't take it. But boy, I worried for 5 years. I worried that I made the wrong decision for me, my family.
Yeah.
So the fact that women could actually have this type of choice and to have almost the best of the medical and your quality of life that you want to have as far as a mother and a parent and a woman. Thank you.
Yeah.
Great.
Yes. So
yeah,
it is reassuring. Again, I think the caveat with any research study would be that, we have to still, continue follow up. women are supposed to restart their endocrine therapy. So, to kind of confer that benefit, even though it's a little bit delayed because of the pause. But kind of the take home would be, it seems to be safe to pause.
For that amount of time, successful pregnancy, was able to conceive, ovaries were working, right, despite being on that for 18 months. Do you, Shoshana, do you see that the women then go on it for an additional, what is it? So you're usually on for 5 years. So does that 18 months take into consideration, or do they have to start all over again?
No, I don't think they're starting over. I don't know. I know, as I said, like they enrolled people to 2019. So like everyone's at a different point. They are kind of measuring adherence, and they do in the additional follow-up, they'll have that data about, how long do people stay on. And again, I think it's going to, it might vary based on an individual's, risk. If they're on the lower end of things, decision of whether to extend endocrine therapy might differ. But they're not, I don't believe they're starting over again. It's just they're resuming.
Resuming.
Yeah. And they might extend it because of, extended endocrine therapy for some women. Go past 5 years.
Was there, Shoshana, was there a length of time? So like, for example, if they stopped at 18 months of that endocrine therapy and then they tried to get pregnant and it just didn't happen for 2 years or 3 years, is there a point where you had to say, okay, we need you to go back on?
Yeah, they do have the data. I don't know offhand, to be honest, what proportion of women that applied to. I mean, the protocol was they wanted, this is to establish the safety of it. So, ultimately women can choose to do what is right for them and what they want. So they do have that data in the study about, when women went back on.
I didn't know if there was like a gold standard.
Yeah, I
like
don't.
You can't go in so many years without having.
I think there are probably these individual cases where, some women might have had a pregnancy, there were women who had more than one pregnancy. So they did stop again. So
they were stopping for a longer time.
Yeah. So there will be, I think, small subgroups they'll be able to kind of, at least describe, what happened. Because, the good news was that most women were able to get pregnant, which is just,
I know, it's so good. That was my fear. That was hands down my fear.
Yeah.
So that was what I was making a decision on, right? Is this going to shut me down for good? And I'll never have that chance again. And it takes, your womanhood, cancer takes so much away from you. And what's taking this, that was frustrating, right? So it is so positive that you're able to be able to get these results and even find more findings that you didn't realize you were going to.
Yeah.
I have another question.
Sure.
You're taking me back 20 years now.
Yeah.
So is there any risk of breastfeeding? Like some women will breastfeed for a full year. Are they actually, let's say you're done, and do they want you to go back on that tamoxifen and you can still breastfeed while you were on the tamoxifen?
No, so the recommendation was, in that 2-year window to complete your breastfeeding. So, that should, before going back on.
Yes.
I think the window was designed so women would have that opportunity to breastfeed if they chose.
For that year.
Yes.
Or 6 months or whatever they decide. But
yeah. And we'll talk a little bit about breastfeeding, but the positive trial does have that information. And I believe there's going to be an analysis forthcoming. It might have been presented in abstract form. I don't recall offhand, but I don't know if the paper has been published, but they are going to be presenting that data about the breastfeeding.
Great.
So good. So good.
We'll have to be on the lookout for the formal results of that positive trial. And Shoshana,
it's published in the New England Journal. These primary results are available in the New England Journal. So
perfect. No, that's okay. Well, we love to do our research, especially around this. And I was going to say, I'm not sure if this kind of trial is the first of its kind looking at this population, but I'm curious as to how these findings, if they are providing, if they're really making an impact on how patients are deciding or approaching pregnancy with a breast cancer
Mm-hmm.
diagnosis, right? Like, have you found, or is it really too early in this sort of initial trial phase to really have that down the road impact?
Yeah, I think that's a great question. You just gave me an idea for a new research study about how, how is this actually, changing practice in the real
Yeah.
world. So I think, like Sue brought up, I think women were doing this, and like women are getting pregnant after breast cancer. It's a very personal choice. And it's something many women, really want. So it's been happening. But I think, having this data is reassuring, right? Like this can be presented to patients. We now have more information to be presented. There, as I alluded to earlier, there have been studies that have, looked at this, and pretty much, the data has suggested it is safe to become, pregnant after breast cancer. Like there hasn't been most studies have found that it's, it's safe, but we just haven't had this kind of rigorous prospective data. And specifically, I think answering the question in the women with hormone receptor positive disease because of that endocrine therapy timing, which is why it's so, critical to understand it. So I think this kind of just, again, adds to kind of the confidence that, or the reassurance when women are making this decision with their doctors, with their families. And I think, yeah, we have to do a study to really find from both I think the survivor perspective as well as the provider perspective around, now that we have this data published, how has it changed your practice? How is it, from the patient's perspective also, has your provider, use this as part of shared decision making and survivorship care? So I think it's a great question.
Do you think that with more research that may be looking at this patient population, ideally it could end up as a guideline, some sort of guideline,
Yeah.
a formal guideline? I mean, I'm sure that would be the end result. I can't imagine that there is something in place already. I could very well be wrong.
So there are ASCO guidelines, actually. American Society for Clinical Oncology, which is the main organization that does produce guidelines around all aspects of cancer care, both therapeutic and treatment, and also survivorship, supportive care. And ASCO has actually already had 2 rounds of guidelines around fertility. A lot of it's around fertility preservation. But they have not been updated, I believe, since 2016. So there might be due for an update. And those guidelines are not specific to breast cancer. They're fertility guidelines for all types of cancer. So I would imagine that these clinical trial results will inform any future guidelines. And I'll also I'll give a plug for young women specific guidelines that were originally put out. There was a conference called the Breast Cancer BCY, Breast Cancer in Young Women conference that started, I think, in 2012 by our European colleagues, were the sponsoring organization around that. And there were subsequently, I think they're on BCY 7 now. There have been a bunch of BCYs in there every other year. There'll be, I believe the next one will be at the ESMO Breast meeting, which is in May of 2025. And at those BCY meetings, they actually do have a expert panel come together to review, the guidelines and come to a consensus about different issues specific to young women with breast cancer. And they do use these types of, the updated findings from newer studies to inform the guidelines. And those are also published. If you kind of Google, I believe BCY 6 was the last one. I can't remember. All the years, the post-COVID years kind of meld together. The last one was virtual. It was about 2 years. It was 2 years ago, I believe. So those guidelines are published, I believe, either in Annals of Oncology, and they would, the last ones were published before positive, but positive will no doubt
Absolutely.
so yeah.
Mm. I
So
was
good.
thinking back to what you had said because you have members on this trial from all over the world, correct?
Mhm.
Do you see any differences with lifestyle, nutrition, just the way that different countries
Yeah,
approach
that's a great
that?
question. And I'm not sure, they did have surveys as part of the positive, the larger positive trial.
Mm.
And I'm trying to recall if they had questions about lifestyle. I know they had questions about, I think, fertility, preservation, decision making, and things like that. But I would say like the cultural differences as well as the
Exactly. I was.
differences
Mhm.
in countries, no doubt do influence
Yeah.
some
Yeah.
of these
The fertility issues.
issues. Yeah.
Yeah, I
So
would think so.
Mhm.
It's so good, Shoshana.
yeah.
Yeah.
Great work. I know it's exciting to see, how things will evolve moving forward. And with
Yeah.
that, I'm curious if you are aware if there is any new research that we can expect to come out or other trials that are going on regarding pregnancy and breast cancer, if that's something that we can look forward to in the next few years, perhaps.
Sure. Yeah. There's a lot of exciting research focused on breast cancer in young adults, which is, it's great to see kind of the field growing.
Yeah.
I'll highlight another international study that also recently also published some really interesting findings around pregnancy after breast cancer. And this is actually related to breast cancer survivors who have a BRCA1 or BRCA2 mutation. So not previvors in this study, but all women who have a test positive for a BRCA1 or BRCA2 mutation, who subsequently develop breast cancer. And this is work led by one of the leaders in the field, Dr. Matteo Lambertini, who many people might have heard of. He's
Yeah.
really does great research and has grown the kind of research around fertility and pregnancy after breast cancer through his really innovative and really he's so passionate about it, and he was able to assemble also an international multi-center kind of cohort, and he has, I think, it keeps growing, and his cohort is huge. When I see him, he's already added another
Oh,
center. So it's really, he's probably, I don't know if he's at 100 centers from around the world, but he's getting there. But the research that he presented last year at San Antonio Breast Cancer Symposium was also published in JAMA. Also was looking at the safety of pregnancy among breast cancer survivors with a BRCA mutation. And then it was a little bit different of a study design than the positive trial, which was a clinical trial. This was retrospective, which really in reality just meant they, went back to all these centers and asked them, to identify patients who had been diagnosed between 2000 and 2020 with breast cancer, age 40 and younger, and had a BRCA mutation. And they're all in this large cohort, and they're answering a lot of questions relative to this population, pregnancy being one of them. And there'll be more data presented at this San Antonio, not related to pregnancy, but related to surgical decisions. So they're answering a lot of different questions with that cohort. But in this analysis on pregnancy, they included over 4,700 women, so very large, again, from around the world, diagnosed with early stage breast cancer. And again, reassuringly, also good news, they did not see any difference in disease-free survival between the survivors who became pregnant and those who did not in this, large analysis.
that's
So
great.
that was reassuring. They also were able to report among the patients where they had this data that there was a low rate of congenital abnormalities among the babies that were born. So also reassuring. So
Wow.
yeah, so
Another worry, right?
yeah. So
another
I think
worry.
that was also kind of a little bit of a
Yeah.
data-free zone in that, in the BRCA.
If you have that study, we'd love to see it in the chat. We'll have Rachel. I was looking for it. I don't think I found it.
Yeah, I can, let me see if I can find the link and I could
chat. And then you had said that you'll see more findings at this SABCS. I would love to know what that time and date is, because we'll be there and we would love to go to them.
Yeah, I had to look. Yeah, the Dr. Lambertini will be presenting a different analysis, not pregnancy related, but I'd have to look it up. I could.
We'll get it through email. No worries.
Yeah, I'm not sure
email,
which
but
day
I would love to see that. Yeah,
it's really a tremendous undertaking on his part to kind of bring all this data together. And I think it speaks to kind of team science. Like you really learn the most when you bring people from all over together. Yeah.
Right. So good.
So good. I know. And I remember, Shoshana, you mentioning this researcher, Matteo, before when we met with you before, and just really, he is just a movement in this space. So even just to listen to him speak and share some results, it'll be really exciting. And to even, start to anticipate what we can see ahead. They're very exciting.
That's great.
Absolutely. So jumping ahead a little bit, and we did mention this, I did want us to go back a little bit to breastfeeding after breast cancer, and what do we know about it? Is what we know or what we've been practicing? Do you see an evolution in terms of safety regarding breastfeeding in this space? What do we know so far?
Yeah, so that's also been, a data-free zone for a long time. It's obviously not a new issue, but there haven't been, very many, like I would say, large studies. We always think of larger studies as being a little bit more rigorous, a little bit more representative. That's not to say that, smaller studies, I do some qualitative research, so I do value, smaller studies that are able to kind of explore some of these issues. And I would say most of the kind of studies until very recently that have kind of tried to understand breastfeeding and patterns of breastfeeding and have not been about the safety of it. It's just been mostly about, what are women doing? And they've been mostly smaller, descriptive, qualitative. So our team at Dana-Farber, which is led by Dr. Ann Partridge, who's really is the leader in this field. Dr. Partridge started a prospective cohort of young women diagnosed with breast cancer at age 40 and younger back in 2006, and about 1,300 women were enrolled to that cohort over a 10-year period. And a lot of the cohort has been focused on fertility outcomes and breastfeeding. So our group from Dana-Farber and a few other centers recently did a deep dive to ask women enrolled in the cohort about their breastfeeding experiences. And that was also very recently published. So that analysis had I believe it had 94 women, so a little under 100 women. And I'll just give a plug for the two young investigators who led this study, Dr. Tal Sala and Dr. Camilla Sarori, who led this and led the publication of this. And they surveyed women enrolled in the cohort about their breastfeeding experience. And again, reassuringly, over half of the 94 women did say they attempted to breastfeed. And this is not surprising. The most common reason women did not breastfeed was because they had a bilateral mastectomy. So that was, we know a lot of younger women have chosen to have bilateral mastectomies. So that was the main reason women did not breastfeed, according to the survey. Of the women who did attempt to breastfeed, about 70% had breast conservation. Most reported that they could not lactate from the treated breast, and a small percentage did report that they had a decreased milk supply from the treated breast. The median time that women breastfed was 6 months, but ranged from as little as 2 months to almost a year. And also, I think reassuring was that about 2/3 said that they were satisfied with their ability to breastfeed. So that was good news.
Very good. Yeah. I would love to see that article as
Sure.
well.
Yeah.
Thank you. If you could put
Always,
that.
always happy to share.
It's so good. It's just so good. In our community, they love this data.
Yeah.
They love seeing the journals. They really appreciate it because they take that back to their doctors, and
Yeah,
you know
yeah,
they feel really armed, Shoshana, with information that is going to resonate with them. So that's really positive to hear.
Gives
Yeah,
them hope for sure.
for sure.
Yeah, absolutely. Before we jump over to digital health, because I know that, technology, especially in this population, so much I hear from our members, they're really leaning into this from supportive. But Sue, any other questions that you have for Shoshana about pregnancy, breastfeeding, this kind of research before we jump ahead?
No, I feel like our community is just going to feel so hopeful, Shoshana. I knowing I did not have any of these choices, and all of these questions are now backed by some data, clinical trial, research, to have people feel like they can make a good decision, because I was so worried I made the wrong decision, Shoshana, I was so worried. And to have 5 years of worry, quality of life, right? So you really have done outstanding work, and I'm so glad that we can share all of these studies.
And I'll add one more thing about the breastfeeding, as I just don't want to forget, that I did mention that the positive trials, also going to be reporting out on breastfeeding, as is that Dr. Lambertini's large BRCA cohort. They presented the preliminary results at ESMO this year, and both studies looked at the safety of it, and also reassuringly risk of recurrence was similar among those who did and not breastfeed. Our study, the 94 women, we didn't look, it was a little bit too small of a sample to look at some of the disease outcomes, but these are larger studies that, hopefully the papers will be coming out in the near future. So stay tuned.
Another worry, right? Did I cause myself to be at a higher risk because I was pregnant or had more estrogen going through my body? I'm just visualizing, right? Because I had a bilateral mastectomy as well, and I breastfed 3 children, and the uterus contracts, and then that's all during breastfeeding, and just all these different things that the human body does. That's remarkable. Is there any discomfort for these women that have a bilateral mastectomy during the process of giving birth, and then the after effect, how the body is just coming back and going into, because they don't have the same makeup anymore?
Yeah, that's a great question. We haven't asked that. I don't think I have to look back at our survey. The same survey that asked about breastfeeding, we had some very detailed questions about the pregnancy, and I would have to check back to see if we asked those questions, but they're great questions, and I think I'm going to keep it in mind for my own work, which focuses a lot on surgical decisions.
Right, because I know I had a lot of skin, and I had a lot of skin, I guess, skin left, right? And I didn't get reconstructed right away. So that's the other thing, those that are reconstructed, and is there a discomfort? Is there something that still occurs with the body during this whole maternal experience and afterbirth experience? I was curious on that.
Great points.
Okay. All right, digital health.
Okay, sorry, digital health.
I know. Shoshana, we're sending you home with homework, is what we're doing.
I love homework.
Oh, see, you're just taking me back 20 years. All these questions, that I had and was so worried about, and I'm just so happy you are paving a much better way for our young women.
Yes.
So happy. Yeah.
Absolutely. Absolutely. Okay. So I do want to touch a little bit, like I said, on digital health technology, because we've come a long way. There's a lot to look forward to in this space. So if you want to share a little bit about what is the latest in digital mobile health interventions for cancer survivors, and even if you can touch on what's been developed specifically for young adults with breast cancer, if there are outlets specific to that population, we would love to share them as well.
Sure. Yeah. So I think it's a very exciting time for, digital mobile health interventions in cancer survivorship, and not just survivorship, I would say, in for people in active treatment. Survivorship begins with diagnosis, but I think there's some differences when we think about the types of interventions, even in the digital health space, that would, might be better tailored for people in active treatment versus post-active treatment survivorship. And I'll just say that digital health is very broad. And I think today just we'll focus a little bit about supportive care interventions in that space. And I do a lot of work in patient-reported outcomes, and there's a lot of momentum now around electronic patient-reported outcomes. So that's using digital health modalities to collect patient-reported outcomes from which are reports from the patient, directly from the patient themselves, versus traditionally a lot of reports have been elicited from providers, whether based on observing a patient experiencing a toxicity or a symptom. Kind of the momentum has shifted for relying on patients to tell us how they're feeling, which makes sense, but wasn't always a kind of model of care. So there's been a lot of work, at least in the research space, and I think it's going, everything starts in research, and then we learn how to hopefully do things well and implement them more in the, in the clinical space, not part of research, so more patients can benefit. But there's been a lot of EPRO research, or electronic patient-reported outcomes research, around symptom monitoring. And that's, that actually started in the advanced cancer space, where, many patients are undergoing treatment frequently and they experience a lot of symptoms. And how can we, hopefully identify a high symptom burden and address it in, a very, comprehensive and hopefully timely manner. So that a lot of the initial EPRO symptom monitoring started in the advanced cancer space, and now is moving more to early breast cancer, or early cancer, as to say, and then even in the survivorship post-active treatment space, where especially for breast cancer, with endocrine therapy, there are a lot of symptoms that can potentially be monitored and hopefully ameliorated. So I would say kind of the model and kind of active treatment is this, identifying whether there's a really, burdensome symptom or even dangerous symptom in real time, having the patient report it, having maybe an alert in place for the doctor to address it quickly if necessary, and kind of the, I would say, post-active treatment space, where maybe symptoms are more chronic, don't have to be addressed immediately if they're not really, really dangerous, or it's not an emergency situation. Maybe we could use EPROs to kind of guide self-management. So that's what I've done a lot of work for. And I think that's kind of where it's really for breast cancer survivors, it might be really a helpful way to address some of the kind of chronic symptoms that people have.
Yeah. Is this a technology that in initial form is built into like their EMR or their portal, like, or is this something that's separate that might be like AI based that connects with their team? I'm curious as to what the layout is.
Yeah, so great question. So yes, it's both. Yeah, no, there's so many, it's really exploded. Like there's so many models. There are models of EPROs that are tied into the medical record. There are models that are like standalone apps that are not integrated into the medical record. It's everything. Yeah, it depends. And I think the jury is still out about what's the best model. And, there might not be a best. It's going to depend on, the individual patient, the practice setting, again, where they are in their treatments, what's, these, some of these things are great, but if clinicians are overworked or there's not enough staff to kind of address things in real time, how do you make that work? So there's a lot of like workflow issues. Like, these tools are great. I think the motivation behind them is great. There's a need for, innovative modalities to, whether it's in the active treatment, the post-active treatment, supportive care, whatever space.
Mhm.
You know, we need good interventions. But I think there's a lot of, you know, if you build it, you know, you have to see see if it works. It might work, but then when you roll it out into the real world, there, you know, there are often barriers.
Always hiccups. Yeah.
Yeah,
Like you said,
and
there's
I'll just,
always
yeah,
workflow.
and I'll
Just
just
workflow.
say, you know, these interventions are great, but it's also important to think about what we call the digital divide, and not everyone has equal access to
It's true.
you know,
Yeah.
the internet, to kind of, you know, devices that can support these types of apps. And not everyone wants another app. Like people are kind of, you know, pinged out. They don't want
Right.
their
Yeah.
email to answer, you know, they don't want another app on their phone. So there's this fatigue. So I think these are all real issues. So, you know, these digital health is great, but I think there's a lot of other kind of considerations when we think about implementing these types of interventions.
Yeah.
And only as good as the information you put in, right? That patient. So
Yeah, yeah,
I can
yeah.
imagine there's a disconnect there too, if just on the stress level that they're going through, and then how they actually write that symptom and side effect may just not be close to reality because of emotional, which is normal, right? But you're looking at a text that would be very different than somebody's voice telling you that.
Yeah, yeah. So how can you kind of bring both of those things together?
Correct.
Is that maybe
Correct.
there's a way? It's not,
Correct.
you know, just,
Yeah.
you know,
Yeah.
sending into the ether.
Right.
Is there someone on the other side? If, you know,
Yeah.
if the situation calls for it.
Yeah, just trying, because it is so black and white, the text, where if you're talking to somebody's voice, you're like, okay, they sound calm.
Yeah. I mean,
It doesn't sound like.
the big thing now also is chatbots, like,
Yes.
yeah, the chatbots are being implemented, you know, I think there's a role for them. They're good for certain things.
Mhm.
They're not good for other things, but
Right.
I think there's, I mean, like he's talked about AI a little bit, but the
Mhm.
chatbots are basically that. They're there to
Yeah.
kind of, you know,
Go deeper and
go deep. Yeah.
understand. Yeah. Yeah, very interesting. We have
Very
a couple of our partners that are doing apps as well, and very interesting. They're all on, and when they're aligning with us, it's all about integrative care and nutrition services, and
Yeah.
how to sort of have that at your fingertips, and always as good as what you put in it, but
Yeah.
the outcomes could give you a beautiful wellness plan, is the, is the hope for the
Yeah.
final
Yeah. No, there's
outcome.
tremendous potential.
Yeah,
I think,
yeah,
you
yeah,
know,
for
we
sure.
have to learn how things work, and also how they don't work, so we can
Yeah,
iterate.
yeah.
Yeah.
And just like you said, it's, now the grant is to actually give them the device, the wearable, right? So
Yeah.
that they
Yeah.
don't have the digital divide. So they're looking for ways to go around that, but it is a field that's definitely opening up, and may really be very valuable to some personalities that would lean towards that. Than picking up the phone or doing something in person.
Yeah.
Yep.
Yeah. Yeah. I
Mhm.
think I'm curious what you guys think about around peer support. I think it could really be leveraged to kind of,
Correct.
you know,
Yeah.
bring people together
Yeah.
for support.
Yeah.
You know, a lot
We
of
all know what that
younger
community.
patients really value.
When someone has a community around them, they do better. It's just like
Yeah.
every time Erin and I see our members on our speaker series and virtual hangouts, we just smile because we see the same ones coming back. It's their community
Yeah.
and it's love, and they do better. You do better when you have people
Mhm.
around you that you feel are trusted and love and give you joy and a place to go and purpose, right? And
Yeah.
knowledge. So we always know those individuals do much better than the ones that might come to that doctor's appointment alone, right? And not having
Yeah.
anybody
Yeah.
around them.
Support is
Yeah.
so crucial. Yeah.
Yeah.
Wow.
Yeah.
Amazing. So I think some final thoughts, and in terms of these type of interventions, any thoughts or ideas on how they could be improved to perhaps work through that digital divide, or any other
Yeah.
thoughts or suggestions? I mean, I just love the idea of, we've sort of called out several different varieties of support and digital support, which I think is great, because hopefully there's something for everyone. But I'd be curious what to think about improvements or enhancements, or version 2.0s.
Yeah, yeah, I guess I'll just add that, I talked a lot about, the EPRO, the electronic patient reported outcomes. Um, but there are other, I think, interventions that digital health can kind of, make things more equitable. And I'll give the example of, there are some like cognitive behavioral therapy programs that are available, like either app-based or
Yes,
basically
yeah.
you could access them remotely. Some of them are self-guided. So that type of, availability of an intervention like that, making it more accessible for people who, may not have access to, other psychosocial care, but can sit at home and, use a self-guided
Yes,
program
yeah.
potentially. So I think it, it has
That's
potential. Is that for
valuable.
everyone? Probably not, but it might kind of bridge that divide a little bit for some people who might have, challenges with access or might prefer it. So I think there is that potential. And I think just, we as researchers, we spend a lot of time designing and evaluating. And I think sometimes, to step back and really listen to the users, to the patients, and see, what works for them, how ask them how we can, improve things, whether it's an app. I think at least I do, and I know a lot of my colleagues in this space engage the patient voice when we're developing these types of, studies and interventions. So
So important.
it is, we are listening, but that it doesn't stop with the deployment of the intervention. We have to keep listening and improving. So I think that's, we do the best we can, and
Mhm. I love that you talked about the patient voice being involved in the beginning, because so many times they're involved after. They're
Yeah.
involved after, and then it's like, well, no, right? Like that's not where they would have led you if they were involved in the beginning. So that's really kudos to you to do that, because that's where you find the shortcomings, is when the patient voice is not involved in the beginning. Yeah. Well, this is so good, Erin.
This was amazing. And I think it's just really wonderful to know that there are researchers like you and the team and your colleagues that you work with that are working so hard in this space for this population of patient. And, there is science behind advances in quality of life. And we are just so grateful to you and the work that you do, truly. And I know our community is too.
Thank you for having me.
Got it. Thank you for sharing so much. We got all of those good links too, Erin, which I know that our community will love.
Wonderful.
Yeah. Thank you, Shoshana.
Thank you. So good. So I am sure that we will share all of those links and articles and information about the different trials, along with the recording of this video on our Her Library. So if you are interested in diving a little bit more, learning more about some of the research that's coming out, please be sure to check that out. It's so encouraging and it's so hopeful. And I know that there will be plenty of viewers that will go back and watch and listen that just feel a sense of hope that maybe they hadn't before.
Yeah, and are able to make really good sound decisions, because there's now data and studies around it where there was nothing.
Absolutely.
Yeah, there was nothing. So yeah, it was a good segment.
Wonderful, wonderful, wonderful. So it's a great way to wrap up November. I will say again, don't forget to join us in December for our speaker series on December 3rd at 6 p.m. We'll be joined by Dr. Fayanju of Penn Medicine, touching on recurrence. And then the following evening, we'll have Jacqueline Carmody from Twist Out Cancer for our virtual hangout. That's December 4th at 5 p.m. And we'll be getting creative on Canvas with markers or with whatever creative outlet and utensils you have at home. So it is open for everyone. So please be sure to join us. This recording, past and future recordings will all be on our Her Library. So visit uniteforher.org/Her Library to see all of those segments.
Yeah, and if you haven't picked up the 5 Love Languages book, pick it up. It's amazing. It's a quick read.
Yeah.
It's a quick read. I feel like everyone should have it so they know their love language and their partners.
And the people around them, absolutely.
And the people around them. It makes life so much easier. So
know.
much easier.
I know.
Well, thank you, Erin. Thank you for co-hosting with me today. And again, we want to thank our sponsors. We cannot do what we do without them. We're really grateful for those that present in such a lead way. And that is West and Merck and Daiichi Sankyo, in addition to having support from Lilly, GSK, Gilead Sciences, Pfizer, Immunogen, that's now part of AbbVie. And it allows us to bring incredible episodes like this, incredible people and experts like we had here today, over 40 times a year. So thank you to all of your support.
Absolutely.
And we're going to wish everybody a wonderful, happy Thanksgiving.
Absolutely. We are grateful to all of you. So enjoy your time with family, loved ones, and hopefully we will see you in December.
Yeah. All right. Thank you, everybody. Have a
Thank
wonderful
you.
afternoon.
Bye,
Bye-bye.
everyone.